Yeah, so this was a great initiative started by one of my really good friends, Ajai Chari at UCSF, and it's been really exciting to be a part of it. We just had another one, so hopefully another paper will come out in the near future as updates. But really, it brings a lot of us, folks who do myeloma, I guess myeloma experts, around for a full day of just discussing all the different places in myeloma that we still need better research for. And so really it comes down to transplant eligible versus ineligible patients. The definition has changed and people are transplant deferring. Is it quads for everybody, or are there certain patients we should do triplets for? Is CAR T cell therapy for everybody in second line now that we have cilta-cel in second line, or are there patients that should get it maybe later line because of the toxicity, or even ide-cel? Are there certain patients that do better? And I think it's just a really good paper for people to refer to. I sent it to actually all my fellows when it came out, and it just gives you a better idea of, yes, these are the things we have in myeloma, but these are all the gaps. These are all the places that we don't know how to apply the trials that we've already done or the research we already have, and this is where we need to do more trials. And I think one of the biggest groups to me personally is really the patients who have really high risk disease. So either primary refractory at the beginning, or plasma cell leukemia, or extramedullary disease. And we know that combination therapy works the best for them, and really pushing to knock that disease down, before we take off any pressure means a lot for those patients. And again, I think the bigger thing that we get out of this, the big picture, is multiple myeloma really is multiple. We don't really change the way we treat necessarily for patients yet. We don't have algorithms, but those who are high risk or have, again, CNS, EMD, or plasma cell leukemia really need to be treated differently than patients who have really standard risk, barely any myeloma. Tumor burden, at time of disease relapse or at the time of treatment matters, especially with our immunotherapy. So again, that paper really starts highlighting a lot of these questions, and I'm hoping that the next version will, answer some of the questions we had last time, but then add on to now what are the questions today, and hopefully helps fellows and other faculty, kind of tailor their research to say these are really the unmet needs that we have for our myeloma patients right now. Yeah, no, I think this is a fantastic time to be a myeloma doctor, a myeloma researcher, and we are finally having therapies that are potentially even leading to functional cures. I think someone else has talked about cilta-cel's long-term data that came out at ASCO and EHA, and a lot of these cell therapies allowing patients to be a one and done. I can't tell you how much that's helped quality of life. We have multiple studies we've been a part of that show that quality of life has improved. And again, anecdotally, we know that. So I'm really excited for the next 5 to 10 years in terms of how do we really treat patients but give them time off from treatment, and really improve their quality of life where they kind of feel back to normal again. And I think that's really where the next set of trials and treatments are going towards, minimizing the toxicity, but really increasing the efficacy.